Ladies and gentlemen, you are welcome to presentation of Household Baseline Assessment Survey for implementation of Katsina State Contributory Healthcare Scheme by Dr. Nasiru Lawal, Director Planning Research and Statistics at the 14th World Summit on Management Sciences. Today, February 25th of 2021, I would like to thank the organizers of this summit. The presentation outline is introduction, objectives of the survey, methodology, survey finding, conclusion, and recommendation. A baseline survey is a survey that is done at the beginning of a project to establish the current status of a population before a project is rolled out. It is an important part of any monitoring and evaluation process. Katsina State Contributory Health Care Management Agency was established by Law No. 10 of 2018 as an institutional framework for improving healthcare finances through contribution, premium, or taxes paid into a common pool to make accessible to healthcare service easier by all residents of Katsina State as specified by the law. The contributory scheme has two programs, the formal sector program and the informal sector program. The formal sector contributory healthcare program is designed for employees who have structured salary. These are all elected and political appointees of state and local government, Katsina State public sector employees, those in the state, local government, and state universal basic education board, the organized private sectors for organization with a minimum of 5 staffs, and the tertiary institution contributory healthcare program, and then the retiree program. The informal sector program comprises for those without the structured salary and those under partial subsidy by the government, hence not covered by the formal sector program. Examples: artisans, rural dwellers that are not employed, and other vulnerable groups. The membership consists of community-based contributory health scheme, basic healthcare provision fund, vital contributory program, and urban self-employed. The formal sector program is organized, like I mentioned earlier, for organized private sector, which I mentioned earlier is a process whereby the employer pay 10% while the employee pay 5%, representing 15% of the employee monthly basic salary. While for the public servant, they are expected to pay 2.5% of their consolidated salary, monthly salary, into the scheme. While for the tertiary institution contributory healthcare program, for the student of tertiary institution, where at the inception of the registration, a student is expected to pay a sum of 2,000 naira during registration fee, and this will cover the student all the benefit package of the scheme. For the informal sector program, this program is for those without structured salary, like I mentioned earlier, and the number one program is the community-based contributory scheme. This community-based contributory scheme is for the community that are expected to form a mutual health association of at least 1,000 people. They will come into a group and select a model. We have a model A and model B. Model A is where they will select the board of trustees to be the facilitator, whereby model B is where they will select a technical facilitator to be the program manager. Then the basic health care program is a program whereby it's a National Health Act 2014. This is established by law, National Health Act 2014, and whereby the fund will be predominant financed through annual grant for federal government of not less than 1% of consolidated revenue, which is the total federal revenue before it is shared to all tier of government. The rights and privilege of enrollee are: the enrollee is expected to freely choose his/her NHIS, a National Health Insurance Scheme accredited primary health care facility, is registered with the agency. The enrollee also has right to change primary health care facility after 6 months with the present primary health care facility, and also have right to access care once his or her name is on the current agency enrollee register after proper identification. The enrollee also have a privilege of treatment at the nearest National Health Insurance Scheme accredited health care facility registered by the agency in the case of emergency. You also have a right to add or remove dependent subject to approval by the agency. You can also add extra dependent on payment of fee for those that need to have extra dependent. You can be able to pay 9,000 naira per head per annum, and the dependent must be your wife, or your biological children of less than 18 years. So the waiting period, there shall be a processing waiting period of 90 days before a enrollee can access health care service. And the scope of coverage is for the formal sector program. Contribution for formal sector program cover an employee, a spouse, and 4 biological children below the age of 18 years. The principals are entitled to register maximum of 4 extra dependents, like I mentioned earlier, upon payment of 9,000 per annum per additional dependent, subject to review by the agency. And the benefit package is you can be able to assess the primary level care and the secondary level of care. The objectives of the survey is to determine socio-demographic characteristics of residents in Katsina State, to assess the level of knowledge of health contributory scheme among residents of Katsina State, to determine the current household spending on health contribution coverage and willingness to pay for health contribution among residents of Katsina State. Number 4 is to determine the health-seeking behavior among residents of Katsina State, and number 5 is to determine the access to healthcare service among the residents of Katsina State. We also want to provide an update on the status of Basic Healthcare Provision Fund implementation in the state. Methodology, we use the cross-sectional descriptive design for the study, where the study population comprises all the households living in Katsina State. The inclusion criteria is all the head of household and must be resident of Katsina State, while visitors, temporary and internally displaced persons are exempted from the survey. Sample size was calculated using a simple sample size for the sample was determined as 284 households using a pre-source sample size calculator, and this is the population of Katsina State of 8,536,000 of National Population Commission 2006, with confidence interval of 5, confidence level of 95. The sample size was adjusted to 427 to account for non-response rate of 10%. The sampling technique, we use multi-stage sampling technique, which was employed in the selection of 427 respondents. The first stage involved selection of 50% of the local government area among the 34 local government areas across the 3 senatorial zones in Katsina, using simple random sampling technique by balloting. This strategy was adopted to get a clear picture of the entire state, while the second stage involved selection of 5 wards using simple random sampling by balloting. This come up with a 90 ward out of the 361 ones within the state, and the third stage using systematic sampling to select the household to be interviewed during the study. The frame of enumeration area demarcated by National Bureau of Statistics for the National Agricultural Sample Census 2014 was adopted, where a list of enumerated area in each ward locality was generated and served as household to visit for the data collection. Finding from the household survey revealed that almost 88.5% of the household here were male, and then the highest age of those household here is between the 40 to 55 years of age. Almost 94.7% of them married, and then the number of children in the household is greater than 7 members, for almost 52% household. Majority, which is 56.1%, are within the informal sector, those artisans, farmers, and the business people. And for the employment status, 79.1% are self-employed. These slides try to show the knowledge of the household head in terms of the scheme, where 51% have good knowledge of the scheme, but in terms of benefit package, 41% has good knowledge. Majority, which is 59%, have poor knowledge of the contributory scheme benefit package. Awareness of the scheme, because it is a new program in the states, the awareness is very low, with almost 92.3% of the people have no aware of the scheme. And in terms of for those that are aware of the scheme, which is only 7.7%, majority of them get the information through the radio, which is 46.9%, because of the radio jingles that we normally do from the agency to make awareness to the people. And enrollment status into the agency, because we did not start enrolling. This is a baseline survey where almost all the participants, all the household health, were not enrolled into the program. And then they has facility accredited. Before we did not accredited any facility, which is none of the facilities accredited, but by the time we are going to start this program, we are going to accredited almost 361 facilities to enroll into the program, both the public and the private healthcare providers. No school was accredited for the program before the commencement of the program. While the level of awareness, I made mention of this one, the next slide is trying to show the household income in terms of Naira. Almost less than majority of the household earn less than 5,000 per month, which is followed by those that earn 10,000 to 20,000 Naira per month. Household healthcare expenditure, majority of the household heads in Katsina State healthcare expenditure is via out of pocket, which is 9.3 paid out of pocket as means of healthcare expenditure, while only 0.3% healthcare contribution in terms of informal sector program. Those that fall within this group usually have community-based contributory program in terms of mutual health association program, and then retainership is 0.2. Those that never been to the hospital reported 0.2. The average monthly proportionate amount expenditure on health by majority of residents in Katsina is between 35% to 40% of their monthly earning, which is catastrophic out-of-pocket expenditure. Distribution of health coverage based on occupation, where you see that 99.7% paid out of pocket among the formal sector program people, and also almost 0.3 among the people of formal sector paid by health contribution. Willingness to pay for health contribution scheme. Majority of the people, almost 94.4%, are willing to pay for the contribution when the program kick off. Among willing to pay, majority of people of Katsina State, almost 55%, are willing to pay 500 to 700 Naira to join to the scheme. These slides show descriptive studies for among willing to pay for the contribution, while the mean is 545 Naira. The mode is 600 Naira. Maximum amount they want to pay is 2,000 Naira. This is a health-seeking behavior among the household head, where majority of the household, 64%, are seeking their health in the healthcare facilities, while 36.4% non-facility based. These slides try to show the determinant of place of choice for seeking healthcare service among the household head, where 54% reported quality of care to be the first factor for them to determine where to seek for healthcare. next, which is affordability, followed by proximity. In terms of accessibility, the people of Katsina State take little time, almost less than 30 minutes, almost 83.6% of people spend less than 30 minutes to reach healthcare facility. And the time taken to see a healthcare provider is also short, with almost 60% take only less than 30 minutes to see doctors. Then you have to pay money to get to the nearest facility. Amount spent, majority of the people, about 66.2, paid 100, 200 naira before they reach the hospital. And means of transportation, majority of them is motorcycle. Health care facility accessibility, I mentioned earlier, 30 minutes for them to carry them to the health care facility. Now, for the conclusion, it is realized that finding from the surveyed household shows that majority of the household have more than 6 dependents, and majority of households are self-employed with no formal education, and their level of knowledge, both health contribution benefit package, is very low. Majority of the household head utilize government health facility as the first point of call for treatment during the health event. They do not necessarily do so. Quality of care received in the facility influence this, as reported by the majority of the respondents. Findings also from the study show that over 99% of the households in Katsina State are willing to pay for health contribution. Geographical accessibility to healthcare facility is high, with about 84% of the population living within 30-minute walk to the health facility. The study shows that majority of households, almost 99%, pay out of pocket for healthcare service, and health contribution coverage is low across the state. It is clear indication that residents of Katsina State have faced catastrophic healthcare expenditure, meaning that medical spending of a household exceeds a certain level of capacity to pay. There is low awareness of basic healthcare provision found among the respondents and the insufficient manpower to coordinate the program. The recommendation after doing the survey was extra household members in the household with more than 6 members should be considered for inclusion in the scheme, so that no household member individual will be excluded from the scheme. There is need for the agency to use local language in developing information, education, and communication material, and behavioral change communication strategy should be used with local language to raise community awareness, strong sensitization, mobilization, and increase knowledge of health contribution benefit package for enhanced acceptability and rapid scale-up. There is also need for more effort from the Quality Assurance Department of the agency to be engaged on continued integrated supportive supervision in order to maintain high standard of quality care to residents of Katsina State in the health care facility. To be self-sufficient, the scheme must enroll as many households as possible, since they are willing to pay, in order to ensure adequate risk and fund pooling, revenue collection, premium from the formal sector for the health contribution is relatively not problematic, as deduction should be made from the source salary. However, collection of revenue from the informal sector, such as self-employed in this case, can be very challenging. Informal sector household heads were represented by 90.4% of households surveyed. This needs thorough consideration in developing the revenue collection plan for the scheme and considering realistic time frame for achieving full coverage. There is need for the government to establish more health facilities to cover the remaining 16.4% population to have easy access to health care service for the purpose of achieving full universal health coverage. Finally, it is clear indication that residents of Katsina State have faced catastrophic healthcare expenditure, meaning that medical spending of households exceeds a certain level of capacity to pay. It is recommended that with the implementation of this agency, healthcare service provision will improve due to an increase in the accessibility and affordability of healthcare for all residents of the state. There is need for government to continue inputting more effort in order to complete the remaining 30% gap of the readiness checklist for full implementation of the Basic Healthcare Provision Fund program in the state. Full implementation of the scheme will reduce out-of-pocket spending on health and prevent catastrophic healthcare expenditure among residents of Katsina State. I would like to acknowledge the Honorable Commissioner of Health, Engineer Nuhu Yakubu Nanja, and the Permanent Secretary, Dr. Kabir Mustafa, the Director General of Katsina State Contributory Healthcare Management Agency, Mohammed Tukur Ibrahim Safana, and my colleague of the agency, Dr. Hassan Abdul Samad, who gave me thorough support from the beginning of this project up to the end of this project. Thank you very much for listening.